So I'm Ken Minkoff, and I want to introduce my partners who are here with a consulting team to kind of work with these beautiful people and all of you beautiful people to try to make the vision and the change that people have been talking about a reality. I want everybody to give another round of applause for Terry, Takashi, and Ted, all T's, for really setting a beautiful leadership tone for where we're trying to go together. Please. And I'd like to introduce my partner in all things from Zia Partners, Dr. Chris Klein. And a man who introduces himself as our adoptive father, Dr. Andy Keller, who is from TriWest and was the lead on doing the assessment and producing the amazing report, 169-page report that one of the supervisors actually said was the best consulting report he ever read, and our hearts went out to that poor man. So, what we would like to do today in the couple of hours that we have, and because time is so limited and it's a big group, I'm going to let you know right away that we're not going to have time for a break, but you are perfectly free to take a break at any time because we really need to kind of keep the flow going. And I have a fair bit to share to help you understand what's going on. Some of you have been listening to various aspects of this presentation since the beginning of the day yesterday. Others are brand new to it. I'm going to try to cover some things that we didn't have time to cover previously, but very important to all of us is an opportunity to hear what you guys have to say about what you're thinking before we depart today. And we have microphones and microphone holders and people running out. And some of you have already been picked. You know, we've said to you, we haven't heard enough from you. So if nobody says anything, somebody's going to plop a microphone in your hand. So be ready. And so there's a lot, because it's really about all of the things that you guys are thinking. So in your packet, you have the slides. There are many more slides than we're going to get to go through today. And part of the reason that I'm referencing them is so that you can go back, read through stuff that I went through more quickly than you might have been happy with in order to catch up. But I really want everybody to come out of here understanding the big picture of the change process, the values at the heart of it, and how to get involved. Where is it that I personally, my team, my program, my agency has an opportunity to participate in this thing we're all trying to do what we modestly call change the world in Santa Barbara County ADMHS, and as Terry has indicated, hopefully lots of partners that are not part of ADMHS will have opportunity to join into this as we go. So the first set of questions is, let's see if I can negotiate this, is how did we get here? So we started with a report. And you've already heard, Takashi did a very nice job summarizing the report. So for those of you who've seen me do this before, the first slides that are about the report, I'm going to go through very quickly. So as part of the assessment, there is lots of good stuff, lots of stuff that needs to improve in order to deliver better care that's better matched to the needs and hopes of the people in Santa Barbara County of all kinds of behavioral health issues and other complex needs. But before looking at any particular thing to do, we recognized that what was holding the whole system back was that an unhealthy culture had developed that interfered with the ability of lots of smart people and excellent programs to come together and work together as creatively as they could to solve problems more effectively that would produce better results within the resources available. And we labeled this culture a culture that had experienced trauma and disempowerment, and that trauma and disempowerment was pervasive. So it wasn't just something experienced by people at the lower echelons, but it was experienced throughout all the different layers of the organization, and had gotten in the way of people coming together and being able to produce results that were about a collective vision. So, overarching recommendation: don't try to just fix problems piecemeal, reactively with small band-aids, but let's get together and create an overarching system transformation approach. And we've been amazed at how much that message has resonated throughout the community, of people saying thank you for pointing out what many of us have known for a very long time, and saying it out loud, and bringing in all levels of support to try to actually address it. So part of what we're doing today in what we're calling Kickoff, and actually started yesterday and started even before, as Ted said, that his team has been working on this for several weeks, is to build an empowered, customer-oriented, trauma-informed culture for the entire system, within which everything gets addressed. The culture is based on clinical values, clinical quality, taking good care of people, and organizationally on performance improvement, the culture of performance improvement, the partnership of performance improvement, not fear. Healthy collaboration, not fear. And what we're here to do today is to bring you guys into the process. So there's a sequence of things that, I'm going to be talking about. At the beginning, middle, and end is always about what are our core values and how do we articulate them so that we can all move together to be responsible for doing things in relationship to those values. Within that, we need a certain amount of structure, what we call just enough structure, to get a whole system organized. And so I'm going to share a little bit with you about what that structure is. And there's a process within that structure that allows everybody at different levels to be attached to things. And within that big structure and process, there's opportunities to dig into the details of things that need to be changed and create content and outcomes that are all connected in a much larger process. Okay? And I'll talk more about this as we go. Okay. So this particular slide you've already learned about. There's a clear leadership commitment and a transitional structure. Our relationship as consultants starts with an intensive engagement to support these folks over 6 months, not to finish the process. Okay, so there's a lot of, if you're thinking we're transforming the system, when will we be done? Okay. We've already begun to create change just by starting to shift the way things happen and the way things get connected to begin to create improvements. The goal is not to just run around and do a lot of things and then stop. The goal is to create a sustainable organizational process within which continuing improvement occurs. Decisions get made in an ongoing way. The structures remain as a defining way that the system does business. So our goal in 6 months is to leave you being empowered and organized enough to continue with a lesser level of help and support from us. If that's what you want or need, we can be as flexible as you guys need us to be. Okay. Now, this is about partners at all levels. There's county leadership partners, ADMHS internal leadership, CBO leadership, community advocate partners like members of the various commissions and boards, advisory boards, partnership between clinical services, administrative services, fiscal services, partnership with consumers and families, partnership with people who deliver frontline anything, both clinically and administrative, partnership with populations of all kinds of diverse backgrounds, partnership with other systems, health, housing, criminal justice, juvenile justice, social services, and the like. And today is about beginning a process to work together to build what we're doing around our core values. So some of Ted referenced the structures and the handouts, and I want to reiterate that those are a work in progress. So one of the first, there's a project design committee, which is a little core implementation team that gets excited by things like scheduling meetings and making sure everybody shows up and all the communication winds up on the website. And you can't believe how much time we've all spent obsessing about how to get all of this right. And even then have not obviously been fully successful. But you need a group like that to manage something this big. And at some point in this process, there will emerge what we would call a transformational vision and charter that defines how all of the partners have made commitment up and down and sideways to working together toward a vision. A steering committee, okay? And there's a group called the CEO Advisory Committee that is a representative group, literally advising Terry and Chandra through the course of the assessment. And our usual approach is to say we don't need just an advisory committee that goes away when this is over. A system change that's about partnership needs a partnership group that's empowered at the top of everything to work with leadership so that the partnership is actually steering the design and making collaborative decisions, not just during the course of the transformation, but representing that partnership in an ongoing way. So yesterday morning, we began a conversation with the CEO Advisory Committee saying, how would you guys like to be a steering committee? To which we got, Oli said, absolutely. And a lot of people said, what the heck is a steering committee? And we said all kinds of things in between. But we left with the idea that this is going to be a good continuing conversation to try to figure this out. And it also means that there has to be a discussion about how such a group literally represents the entire system at the table. And that's going to be a piece of work. It usually takes a fair bit of time to figure that out. It's an ongoing process, but that's the idea. And all of those representatives I just listed need to feel and experience representation at that table. Okay? In addition, ADMHS holds responsibility for its own internal operational leadership. And so part of our job is pulling that group together, which is a bit of a work in progress right now, and getting to the point where everybody says this is the current iteration of the ADMHS internal operating team, okay? The Tiger team is that some of you have heard about, which is kind of a kind of cross match between public health and behavioral health, is going to be sunset. And there's going to be a focus on developing specific operational teams within each area under Takashi. And so that gets defined, and it's going to help everybody know who's accountable for what, within what framework, and so on. And it may change, but at every point, clarity and transparency means that gets defined, because that helps everybody in their role to be clearly empowered. We're likely to wind up with regional change teams for certain activities. We've gotten the idea that even though we're all one, people in the north have different sets of experiences than people in the south and people in Lompoc. So part of rational design is some things have to be county-wide and some things have to be figured out regionally. And the folks who are responsible for regional activities, like regional managers, need the empowerment to figure out the layers of design that they can create within this larger process. And we're going to be working on a team of change agents starting right after lunch today. And we're welcoming people into that discussion, not only, I mean, anybody who wants to learn about change agentry, even if you don't want to be a change agent yourself, but you're thinking, I'd like to find someone else in my organization to be a change agent other than me, but I want to know what a change agent is so I can twist their arm, please come. Okay, because it's an open discussion, and change agentry is a very important way that the voice of people at the front line, service recipients, service deliverers, administrative support staff, representing all of the different components of the system, come together and become a single team and an empowered voice that informs the process. Consumer family advocacy included everywhere, okay, and not just one person, but thinking about how the representative voice of consumer and families are represented throughout these different processes by the people who feel best suited to be those representatives. Okay, and then out of this, developing an articulated transformation plan that's visible, accountable, measurable goals and objectives for each of the many, many things that were identified in the report that need to be addressed. Now, within this structure, not outside the structure, there's lots of work to be done in this thing that Ted referenced called action teams. So some of you will want to participate in system improvement action teams around various topics. Others will have other places you want to get engaged. Okay, there's no matter where you are and who you are, if you're interested in doing something, there'll be stuff to do because it's about the whole system, and I'll explain that momentarily. And this is a list of all the different areas. You know, recovery-oriented trauma-informed system, children's systems, cultural intelligence, as Chris and I like to call it, primary care integration, mental health substance integration, crisis redesign, access improvement, continuity improvement, peer support engagement, criminal justice collaboration, homeless services, employment improvement, and developing the administrative and documentation infrastructure that legitimately supports our vision and values in every aspect of policy, procedure, and practice, and creating very strong compliance monitoring that is consistent with the values that we're trying to create. Okay? So this all sounds maybe a little radical and overwhelming. The good news is no one person has to do all these things. That's why so many partners are needed. Part of the way we approach this in systems is the more people are organized and empowered to contribute to the change, and lots of different activities get beautifully organized by your design support team, the more stuff gets done through a process that's called, and you can Google this if you're interested, called collective impact. Lots of people doing lots of things, not all doing the same thing, to move a system in the direction of a very big and important vision. And today, we're here to put this all together. Now, this is our standard opening slide. Some of you, by the way, may have seen me present on mental health and substance integration back in 2006. I've had a couple of people come up and say, "Hi, do you remember me?" I'm like, "Oh, yeah, sure." But, you know, and a lot of the work that Chris and I do comes from, you know, we've been working together for 12 years, and we're in the Changing the World business as Zia Partners. And we started when Chris was medical director for behavioral health in the state of New Mexico, and working with stuff that I had put together, you know, as both medical director and executive director of lots of provider delivery stuff all over the place. Massachusetts, other states, mental health addiction, inpatient, outpatient, blah, 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 blah. And a lot of where we started had to do with developing big system change around mental health and substance, and that was the focus of what I was here 7 years ago. But over the last period of time, we have gotten into doing all of this around many, many issues, okay, as you'll see, and in bigger and bigger system transformation activities. So what we do is, what we're doing here, is we consult all over the world to large systems, usually public, commonly behavioral health, but health systems, housing systems, criminal justice systems, children's systems of care, in the United States, in Canada, in Australia, state systems, county systems, managed care systems, private sector systems. Helping systems organize themselves at every level to be about the needs and hopes, as you've been hearing everybody say, it's like, woohoo, you know, of people and families who are coming to our doors and sometimes not coming to our doors. We have to go find them. Okay? And this is a very big deal. This is what it means when we talk about transformation. It's about the people showing up. And the biggest driver for doing this in systems like this is that for quite some time now, people and families have been showing up at our doors and letting us know in no uncertain terms that with all their complexity, they don't experience our system to be organized to be about their needs and hopes. The people show up with all kinds of desperation, all kinds of challenges, and they encounter systems, structures, rules, regulations, bureaucracies that make it feel like the job of getting help when you're desperate and complicated is going to be as hard as possible. Not only do the people we serve experience this, so do we. Most of us went into this business, and I always say the same thing for those of you who heard this before, not because we thought this was a cool way to become a millionaire, but because we had the weird idea we wanted to be about helping people. And we too go to work inside the big system, and in 5 seconds we find ourselves immersed in all of those same rules of operation, and then we find ourselves experiencing how difficult it is out of our hearts, our mission, our values to be helping the desperate people in front of us. And what we're starting to realize, and this is not just because Santa Barbara County's been having a hard time, this is an issue everywhere, is that we're never going to get where we need to go in systems with limited resources, simply by trying to figure out special programs, special projects, special funding streams that work around a dysfunctional system. We need to be thinking about how do we organize everything we do. Every program, every person, every policy, every procedure, every practice, every piece of paperwork with every penny that we have to be about the needs and hopes of the people that we're serving and the values that got us into this in the first place. And if you think that sounds radical, that's because it is intended to be radical. We don't want to start the way we think by shooting low, by saying we'll be about the needs and hopes of people if. Okay? It's about every resource that we have, and we have a lot of resources sitting together right here. Come together to think about how we design everything. Now, in doing this, one of the things that we do on purpose is in every process you start thinking about how are we designing the thing we do, whether it's our program, whether it's our paperwork for documentation, whether it's our crisis system, whether it's our access flow, based on the assumption that we have to be about the people who are actually going to see. And we can't just design things on the people we think fit us easily. Our job is to figure out who doesn't fit so well, because those are the people who need us the most. And we call this the complexity challenge. And we can talk about complexity in lots of ways. You know, there's stuff about integration up there. So complexity may mean you have mental health and substance issues. Complexity may mean that you have behavioral health and health issues. Complexity may mean that you don't speak English, or you come from a different country, or you come from a different culture than the one that we organize our services in. Complexity may mean that you've experienced trauma, not just in your early life, but in your previous experiences with receiving care. So you're not actually feeling like this is an easy thing for you to be doing, showing up asking for help. Complexity can be that you don't have a place to live. You've been arrested, you're on probation, you're in trouble for abusing your kids, neglecting your kids, not knowing how to be a great parent even though you would like to be in your heart. There's all kinds of ways that people show up with complexity, and families show up with complexity. And we say, let's think about who these folks are, because we know that everybody here is dealing from your heart with people with complex challenges of all kinds all the time. And why do we want to start by thinking about these people in the middle of our collective conversation? One, the more complex you are, the worse you're likely to be doing. So these are the folks who are likely to be having the poorest outcomes and the highest costs in all different domains. Second, if our job is to design our system to be about the people who need us, naturally we would want the people who will have the most levels of complexity and complex challenges, mental health and substance, co-occurring, this and that, to be clearly prioritized for system level attention. But what we experience is just the opposite. These folks are often experienced as misfits at every different level of the system. The way the funding instructions are designed, the way the programs are designed, the way the clinical flow processes are designed, the way people's own levels of competency are experienced. I'm a mental health person, I don't do substance. I'm a substance person, I don't do mental health. I'm a health person, I don't do those. I'm a behavioral health person, I don't do health, etc. Not only do we experience people as misfits, we wind up experiencing them negatively. Because when people don't fit well, okay, they don't easily do what we want in order to achieve the outcomes that we would like them to have. And we start getting feelings. We feel hopeless, helpless, we feel frustrated and enraged. And people start acquiring labels. They become the antisocial, manipulative, borderline, med-seeking, non-compliant sociopaths. And we often are introduced to them by our colleagues before we've ever met them. We're having a moment in the front, in the third row here. I don't know, she's pointing at him like, hey, I've been telling you you're an antisocial, manipulative, borderline sociopath for years. And see, it's true. I don't know what's going on here, but they're having a moment. So anyway, so the people who need us the most on many different levels, instead of being prioritized for care, wind up being held at arm's length. And you can think about how this happens in the system. We've heard lots about it from the focus groups, the surveys, or the assessment, etc. So one of the starting places for thinking about how to redo this is, how do we create a system at every level where the people and families who have the greatest challenges, who need us the most, are specifically, purposefully, and proactively welcomed for help exactly as they are, even when they may have no insurance, wherever and whenever they show up. Here's the next challenge. We call it the Hope Challenge. Okay, and I'm defining just a couple of fairly simple core values. We have to actually be about the people we see who have all these challenges. We have to welcome them as they are, and we have to inspire them with hope. Most of you know from your own work that even when you feel you don't have the perfect referral to offer, you don't have all the resources in the world to fix people, which we rarely, if ever, do, and it's not even our job to be fixing other people so much as partnering with them on their own journey. The thing that we always have access to providing, which is actually amazingly important, is hope. And if we're not conscious about providing hope, particularly when we meet people who initially we feel like, I'm not sure what to do to help you, then we wind up taking people's hope away, which is catastrophic. And one of the things we don't want for you is to be the system that inadvertently takes people's hope away. So part of this challenge is to say we have to be conscious in everything we do that people who are so vulnerable when they meet us do not re-experience trauma at our hands, experience welcoming as they are, because in the moment they cannot be anyone else, and they come away from any contact we have with a sense that they have received more hope by virtue of knowing us than had they not. And we think about how to do things like that throughout an entire system. So you ask yourself, how well are we doing? Ooh, opportunities for improvement. Okay, here we go. So we're talking about a system of care. Now, this is language many of you have heard: recovery-oriented systems, trauma-informed social and children's systems. But the idea of a principle or value-driven system is, first of all, you have to articulate your values. And then everybody has to commit to them, because your values don't go on in the special value program. Oh, thank you for having MHSA. We can have some value-driven programs funded by MHSA. You know, that kind of thing is very common in California. Everybody's got to be in the value business. So this is what we mean by transformational change. It's about embedding something in an entire system, which is why all the partners are needed and why everybody has a piece of the action. What's a system? Oops, oh, I forgot something. The other driver for what we're talking about with complexity is not only are these folks doing poorly, there are lots of them. So complexity is an expectation, not an exception, no matter where we look. And it's not that you don't know this, you live this every single day. What's striking is the extent to which we have a set of values, our system is mismatched. We have complex people, our system is mismatched. We have all these people with poor outcomes and high costs, and we are designing them into mismatched services, guaranteeing poor outcomes and high costs. All the while we sit hoping for new money so that we can deal with the weirdos. They're not the weirdos, they're the normal people, and we're never going to get enough new resource to deal with them all. And the more that systems are mismatched to what's actually happening, the less effective and efficient are the scarce resources in producing good results for the people. So we're trying to build something that's about everything. All services are designed to be welcoming and hopeful, empowering, strength-based, and addressing the expectation that the next person or family you see will have multiple issues